Welcome to Emergency Insights. I'm James Carter. Today, we're discussing a critical aspect of respiratory support, positive end-expiratory pressure, or PEEP. While often a cornerstone in managing respiratory distress, there are instances when more PEEP may not be better, and can, in fact, be detrimental. It's common practice to increase PEEP, often in conjunction with the fraction of inspired oxygen, or FiO₂, to enhance oxygenation in our patients experiencing respiratory distress. We are all acutely aware of the adverse hemodynamic effects that high PEEP can elicit, such as reduced venous return and subsequent drops in cardiac output. However, it's equally crucial for us as clinicians to recognize that excessive PEEP can, paradoxically, worsen oxygenation in specific clinical scenarios. Let's delve into the physiological rationale behind this. In patients suffering from lung disease, high PEEP predominantly distends the more compliant areas of the lung, essentially the healthier lung tissue. This distension exerts pressure, compressing the intraalveolar pulmonary blood vessels within these well-ventilated regions. This compression subsequently increases vascular resistance in those areas. As a direct consequence, pulmonary blood flow is redirected. It's diverted away from these well-ventilated, more compliant regions and instead shunted towards the less compliant, often consolidated and diseased areas of the lung. These diseased regions are less affected by PEEP and inherently offer lower vascular resistance. The critical outcome of this redistribution of blood flow is a worsening of the ventilation perfusion, or VQ mismatch. More blood is now passing through poorly ventilated, diseased lung tissue, leading to an increase in hypoxemia. This is the paradoxical effect we must be vigilant for. So what's our key clinical takeaway here? High levels of PEEP can indeed aggravate hypoxemia, particularly if a drop in oxygen saturation is not readily explained by radiographic findings. When a patient's oxygenation unexpectedly deteriorates, always consider excessive PEEP as a potential contributing factor. It is imperative to consistently correlate PEEP settings with the individual patient's lung mechanics and their dynamic oxygenation response. This understanding is rooted in the consensus in critical care literature regarding the physiological and clinical impacts of PEEP titration in acute pulmonary disease. By recognizing these nuances, we can optimize our ventilatory strategies and ultimately improve patient outcomes. Thank you for joining me on Emergency Insights. I'm James Carter, and I look forward to our next discussion.